So when we talk about wound healing, here we are talking mainly of wounds which heal by secondary intention. So that is the main thing, because the uh, wounds which heal by primary intention means we have sutured the skin back. Generally, dressing is very straightforward and simple. We'll have some mention about it, but most of the talk will be around wounds which are out there open with no skin cover, which obviously mean that they are healing by secondary intention. So in these wounds, immediately the initial first phase is of hemostasis, mainly where vasoconstriction happens, a fibrin plug forms, and which stops the bleeding, and all the platelets and initial coagulation cascade is started. So that is happens between first 24 hours and then continues till maybe first 1 or 2 days. So in that phase, mainly the coagulation cascade and complement system activates, and kinin pathway, they get activated. And they basically, if you think like an excavation, the wound is like an excavation. So all this process, they just fill that space with the granulation tissue, and uh, will not call it granulation tissue at this moment, but just fills up that defect with some platelets, some fibrin, and all that. This is a very fragile tissue yet, but it initially forms the place on which the tissue can work. And then as soon as this bleeding is stopped, then the fibroblast comes in, and then the fibrous elements, which are little tougher elements, they start coming in the wound, and the wound start taking some shape and structure. And at this stage, generally, if the wound is smaller in the mouth region, the skin starts coming up. And you will find that in most of the small wounds, at least in first 2 3 days, the skin cover is the first thing the body tries to cover as soon as possible, or the skin side. So, and then as soon as the skin cover is done, then the angiogenesis, collagen deposition, wound contraction, all that system starts. Till the time skin is out open, the granulation keeps happening. This process keeps on going on. And once this is done, then comes the late wound healing, which is mainly the wound contraction and the fibrous elements coming in. The scar formation generally begins around 21 days and can go up to sometimes 2 years also. So it is said that the wound healing keeps on going for a very long time. But for us, the phase of first 4 days before the skin takes cover, I think that is the phase which is very important for dressing point of view, because one of the core element or core purpose of doing a dressing is to provide a cover so that the wound is separate from the external environment and infections and other things, the physical forces, so that it can heal in properly and without any interference from external environment. So as soon as the skin comes, I think it is important saying that skin is the best dressing. That is important, huh? The skin is the best dressing, whatever way it comes. So so this is what happens. This again process which happens. Now, sometimes we see that a wound is not healing. Okay, so if the wound is not healing, as per definition, we say if the wound is not showing any active signs of healing or improvement over a period of 4 to 6 weeks, in spite of the best care possible, okay, then we label these wounds as non-healing wounds, and then we should investigate into what are the causes why it is not healing. And so what okay, so so then at this time we should label them as non-healing wounds and investigate into the causes. Sometimes what happens is, let's say there's a ignored wound, person has not sought any attention, medical care, and was a destitute, let's say, and he comes with 1 month old wound which is not healing, we'll still not label it as a non-healing wound because the best medical attention was not given to this person. So that is why I'm emphasizing that line, that in spite of the best attention, the wound is not showing any healing. What can be the various causes? There's a huge list. There are some intrinsic factors, which are the patient's own conditions. There can be some metabolic disorders like diabetes and other things. There can be healing issues, the collagen disorder, something which are internally in the wound. And then there's something can be extrinsic factors, which are in the body itself, but not in the wound area. They're not the local factor. You can also say that they can be local factor and they can be systemic factors. So if there's a foreign body in the wound, if there's a necrotic tissue, if there is a repeated trauma, the wound is at a point where repeated injuries are happening. For example, in the foot, in the sole. So the wound is there, but patient again walks. The wound is aggravated. So repeated trauma is another thing. Ischemic wounds, obviously, because the healing is not there. Same way is venous insufficiency. Unless you treat the cause, it will not heal. Infection, especially infections like tuberculosis, fungal infections, all these infections are very chronic infection. They will not let the wound heal properly. There are some internal factor deficiencies and collagen disorders. Irradiated tissue, again, because the vascularity is less in these tissues. Systemic factors include diabetes, patients who are on steroids or immunosuppressants, anti-cancer cancer drugs, smoking, collagen disorders, repeated traumas, and chronic disease status like chronic liver disease, chronic renal disease, all that causes these. So, and as soon as you get these wounds, you should investigate the patient properly, try to treat the cause, and then the wound will start healing. Management, wound management, there's some proper principles that we have to do is assessment, that what kind of wound it is, at what stage of the healing the wound is there any infection or not, and then accordingly we plan. Okay, whatever we manage, whenever we inspect the wound or treat the wound or dress the wound, should be always done under aseptic conditions. Okay, even if you're treating grossly infected area, you should not add on to a new kind of bacteria because that will complicate the things. So even though you're draining a pus and you can say there's already a lot of infection, so does it matter that if you are also introducing some infection? But what infection you are introducing or it may get introduced is maybe different from the inherent, and which may be more catastrophic for the patient. The dressing will be done moist. We'll talk in detail about what do we mean by moist dressing. And it should minimally disturb the wound. The granulation should not be disturbed much. Like if there's a granulation is there, it is healthy. We do not go on scratching the granulation and destroying the granulation. Okay, so these are some important principles which we follow when we dress the wound. Now the question comes that we should understand why are we doing dressing? What is the purpose of doing the dressing of the wound? We can leave it open also. So the dressing is done, the first foremost is to protect from infection. Now we know that if the skin is a very good barrier against infections, okay? So if the skin is lost and the wound is open, the wound is susceptible to infection from outside air. It can come in contact with clothes. It can come in contact with the other things or surrounding objects. So the infection can transfer to the wound very fast. That's why dressing has to be done. Second thing is, if the wound is producing a lot of exudate or secretions, then the dressing will be able to absorb it, and it will not soil the clothes, the surrounding, bed sheets and other things. And also it will prevent other people who are living with this person from the cross infection. Also, it maintains a moist environment. So if the dressing is not there, the tissue will lose a lot of water. And obviously we know that if the tissue is too dry, it will be very fragile. It will be prone to injuries and death. So that's why dressing generally maintain a good moist environment. It will also prevent from mechanical injuries from outside. Because if it is protected, if there is some covering, and it will not come in contact, nothing will touch the wound directly. So it is seen that the pain relief is also much better if the wound is properly dressed. Whereas you can imagine if there is a cut and you're not applied a band-aid or something, and you keep touching something, so it gets a lot of pain. It also helps in creating a hemostasis. So hemostasis is also there, and Also, sometimes the discharge which is there is very foul smelling. So that also is taken care of if you do a proper dressing. The wound looks clean, there's no odor and all that. A healthy environment is provided. It is cosmetic. Obviously, the dressing, if nobody likes a sight of a ghastly wound where pus is oozing and all that. But if there is some dressing, the patient's psychological state is much better. Patient can talk, meet people, can go out because the dressing is done properly. Also, many times we use dressings to deliver some medicine. There's some medicated dressings, or we apply some medicine, then we apply dressing over it so that the medicine stays in place and it gets to act on the tissue. Monitoring and assessment. Yes, we can directly visualize monitoring, but also we monitor a wound by how much soakage is there. So we can say that, okay, yesterday it was a 2-pad soakage, today it was only 1-pad soak, and maybe today is just a gauze piece soak. So in this way also we understand that the wound is improving or not improving. So it is also, dressing is also used in monitoring and assessment of the wound. Also, it helps in prevention of adhesions with the other things. Can imagine if it can stick to, if the dressing is not done properly or not done at all, some cloth or something can get stick to it, and then when you're removing it, it will destroy the granulation tissue. So again, dressing has a role to play. So these are the purpose of doing a dressing. Now, whenever you do a dressing, you should understand that what are the main purpose in that particular case, and then accordingly your dressing should be able to provide the answer to that. Okay, so that is why, because let's say if you're doing it to make it cosmetic and your dressing is not very cosmetic, so you can understand that the purpose is not fulfilled. Then dressing should look good. Okay, should look decent. So that is the purpose of dressing. Okay. If we try to classify dressing, there are various ways by which we can classify dressings, like let's say according to purpose. So the first and foremost dressing, which will be, which we call as a primary dressing, is the one which is the lowest level. So if there is a wound like this, the first dressing which we apply is the primary dressing. Okay. Now this primary dressing mainly is in direct contact with it. So ideally it should be little moist. It should be medicated if at all is needed. If the wound is producing a lot of secretion, then it should be absorbing it. So properties of primary dressing will depend on the kind of wound it is there. Now directly above that comes a slightly thicker layer of secondary dressing, which covers the primary dressing. Mainly it is, generally we use it as an absorbent, so that the primary dressing is kept in place properly, and it keeps it in place. It can be then secured with tapes and other things. So generally pads and bandages are used as a secondary dressings. It can also be according to the need. It can be an absorbent. It can be uh, colorful. These days we see casts which are there, which are very colorful and all that. So you can do whatever in this. And then we get something, sometimes, not always, we do something as a occlusive dressing or not. In some cases, we have to apply a occlusive dressing, which will not allow the wound to to have a contact with anything outside. So then generally these are plastic sheets or tapes which we apply. So that can be over that. So these can be the various parts of a dressing. Now, according to the nature of the wound, we can do dry dressing. If there is a wound which is having very less exudate, then we don't need to do something. We can just do a simple gauze dressing, because it need not absorb anything, because there's hardly any exudate in this kind of wound. But it needs to just keep the wound secure from the outside and prevent any further infection. Most of our primary dressing, where we have sutured the wound and then we are doing dressing, is also like dry dressing, because there's minimal exudate. So most of our post-surgery primary intention healing wounds is also by dry dressing. Now, sometimes we have, when we do debridements where the wound is wet, means it is causing secretions, and we want the dressing side of it to be little dry. We don't want the dressing to be wet. So that is called as the wet to dry dressing, which will have a gradual degradation. So for example, there's a wound, it is wet, it is causing secretions. We'll have a layer of a moist dressing, then we'll have a layer of dry bandage. So this part remains dry. Now, this is very important to understand here is the purpose of bandage is to avoid any seepage of external bacteria into the wound or any microorganism into the wound. And remember, wet medium or moist medium is the best medium for bacteria. Bacteria love a moist medium to grow. So if this surface also is moist or soaked or wet, then bacteria find it very easy to go into the wound. Whereas if outside surface is dry, then bacteria will not be able to enter it. So our purpose is always that this outside surface of the dressing is always dry. And the inner surface, because obviously if it is too dry, inner surface is also dry, then it will cause problems to the wound healing. So inner surface should be slightly moist. Okay, slightly moist, I'm saying. It should not be a soaking wet gauze or something we are placing. It has to be slightly moist. So this is what we have to end up. And that is why we always say, as soon as this gets soaked, you have to remove the dressing and change the dressing. And if you suspect that wound is producing a lot of secretions, then have a big, like good amount of padding so that the outside surface remains dry. So these are some tricks which you will, if you apply, it will look good also. You know, again, just imagine nobody likes a dressing which is soaked with pus or blood. So that's why it has to be kept in mind. Then sometimes again, there depending on the tissue, like for example, if bowel is exposed, we do not want a dry dressing at the contact site. Even it is even more important. So then it is called wet dressings. So in some sites only where moisture is required for a proper thing. So some tissues which are not supposed to be exposed to outside, again like bowel, like bladder, other things. So then we have to do moist dressings. Whereas if muscle, skin, dressing wound are there, that's okay. It can be slightly less moist. So that is different. Also, according to permeability, we have talked about it, that we can use either occlusive dressings or non-occlusive dressing, depending on what we want. Mostly the skin and subcutaneous tissue heals very good if there is a slight exposure to air. So we like it little porous kind of dressings. But again, if the bowel and everything is there, it can be occlusive because inherently they do not communicate with outside air. So there's no need to do anything. Then we also have what kind of materials are used. So we have a lot of materials and we'll have a huge list we'll show you. The list is ever growing, and according to your needs, there will be customized dressings available if you're ready to pay the cost of it. But what I'm trying to tell you here is, if you understand what kind of thing we need at the wound, I think you can customize it at your own level or the low cost level also. So the various items are available are hydrocolloids. Hydrocolloids generally will keep it slightly moist, the wound. So whenever you want the wound to be slightly moist, then you can use hydrocolloids. Hydrogels also, what they do is the hydration is little more than the hydrocolloids. So because of this moisture, it breaks down the necrotic tissue. So it helps in debridements also. So in these sites, we use hydrogels. Foams are, as you can understand, foam is an absorbent. So whenever the wound is secreting a lot of exudate and fluid, then you can use foams, which will absorb all the extra, fluid, pus, blood, and keep it dry. Alginates have even more absorptive surface. So without making the dressing very heavy, alginates can absorb a lot of blood or these things. Also because it swells as soon as it comes in contact with moisture, it can cause some local pressure effect. So it can be used in bleeding wounds. Transparent films generally are used when you want to observe the wound continuously. And so then you can use these kind of dressings. It provides you an option of visual inspection without removing the dressing every time. Again, and one thing I want to say that whenever you remove the dressing every time, the granulation is also peeled off. A part of granulation also will be peeled off. So the saying that if you do multiple dressings every day, it will be better. No, it is not. It is, dressing should be done when it is needed. It should not be done at every hour or something like that, just to show that I care for this patient a lot, so I will do repeated dressing. Because every time you remove dressing, you're ripping off the layer of granule. Okay, so now what should be an ideal dressing be like? Okay, now ideal dressings is still, there is no one dressing which is ideal, but if we try to define an ideal dressing, what it should be, the one, obviously it should be sterile. It should not cause any allergy to the tissue. It should be non-adherent and non-toxic. Obviously, it should not create toxicity to the local skin. And it should not stick very tightly, because again, the same thing, if it adheres, then you'll peel off again granulation tissue when you remove the dressing and further cause trauma. So it should not stick to the healing tissue. It should be easy to apply and remove. It should be easy to learn. It should not be very complicated in terms of how to do that dressing. It should be permeable to gas. Again, it has been proven that the atmospheric oxygen also plays a role in healing. So it should be generally permeable to gas. The tissue, it should be absorbent so that it absorbs any secretions which the wound produces. And obviously, if we are cost effective, nobody likes to spend too much if it can be done in less cost. So the dressing should be cost effective. Now, whenever, again, now let's say you have a dressing, you have a wound in front of you, it has some inherent properties. You understand, okay, now I require, maybe in this case, I require a moist dressing. Then think about these things, that which are the best dressing which will fulfill these criteria. And that will be your ideal dressing for that particular case. Now, okay, so this is, again, the list and products are huge. You can, a good advice would be to contact your local, providers, or what all dressings are available in your hospital or in the market around you, and try to read through that. Now, again, just don't be bothered by too many names and too many things and what it does. Try to understand what it does, okay? And you will be able to find out what is there. Like non-adherent dressings are there, which will not have any absorptive surface or something. So you know that these are some Vaseline gauze-like things, which where, so you will want them to apply where you don't want any kind of adhesion to form. So like in bowel, exposed bowel is there. You would not like the dressing to get stick to that. It would be a scary sight that you peel off a gauze piece from the bowel and there's a hole in the bowel. So that's why we use something like Vaseline gauze or Fairleys or these kind of materials. So non-adherent dressings are there. Absorptive dressing we have already talked, where you will use. There can be various uh, tissue types which are available, or artificial tissues or fabric are available. Hydrocolloids, hydrogels, foam dressings, transparent dressings. Antimicrobial dressings are also there now, which are impregnated with other different things. There are natural enzymatic debriders are available. There are dressings available which has extract which will promote wound healing. There is a negative pressure dressings are available, which utilizes vacuum to clear out the secretions as well as to improve healing. There are barrier creams available. A lot of things are available, but we cannot just randomly pick one product and start applying it. Okay, we have to understand where what is required. Now, a question comes. I think the residents typically are bothered about this question, that how frequently should we do a dressing? Okay, it's like every day, twice a day, once every week, and and in our residency days, people used to say, okay, this dressing has to be done 3 times a day. This dressing has to be done once a day, and we do not understand what is happening. Okay, so I'm giving you a rule that a dressing has to be changed in these 3 conditions only. Okay, so you can understand. Once, if it is soaked on outside, then it has to be changed. If it is getting soaked every 3 hours, it has to be changed every 3 hours. Or you can be smart and start applying more padding so that this soakage is less. So again, so what we generally do is, if the soakage is too much, we apply a good amount of absorptive dressing and use good absorbent material, then the frequency of dressing will be less. Purpose should be you have to reduce the frequency of dressing as less as possible, because we don't want to irritate the healing tissue. We should keep it in rest and let heal. Okay. If there is any unexplained fever, so if there's a patient who has a dressing in place, even though it is not soaked, but the patient is saying, I have fever, this lung is okay, urine is okay, everything else is fine, then you will have to open the dressing and inspect the wound. In those conditions, again, we'll inspect the wound and open the dressing. Also, in case of unexplained pain at the site, so if there is too much of pain which is not fine because it is not explainable by the disease or anything else, then you'll have to again see what is happening. Maybe some gangrene process is happening. So in these three conditions, you have to open the dressing and change the dressing. Otherwise, if the dressing is dry, patient is comfortable, there's no need to change the dressing too often. Okay. So I hope I have made some of your work easy by this. Now, again, we'll just go through one by one what all we use. I'm sure this is the commonest thing available, the dry gauze, and sometimes the cotton is put in between a layer of gauze piece to make it as a cotton pads. Do not apply cotton directly because it sticks to the wound and it's not a very good thing. So gauze piece can be rolled over a cotton piece. Again, cotton pads, generally, if you see these two things, this will be the absorbent, this will be the non-sticky part. So generally, we'll use this as the primary dressing in contact with the wound, and this will be the secondary. And the layers of padding can be depending on how much is the secretions from there. And then you can use a roller gauze or a bandage to just hold it in place. Again, hydrocolloid hydrogels are available, which are adhesive material, and there has a medicated part or the hydrogel part. Bed sores and all that dressings, generally they can be used. So they have a very less absorptive capacity. For example, hydrocolloid has a very less absorptive capacity, but it maintains a moist environment for the wound healing to happen. So if the wound is not producing too much of exudate, you can use hydrocolloid. Bed sores, again, is a case where generally these are used a lot. And once you apply this and you know that the wound was not actively infected, I think ideally we advise that it should be left for at least 5 days. And then you will change only when the patient is saying that maybe some pain is there or it has got solved or it automatically came off. Hydrogel has slightly more fluid content. Again, as we said earlier, it is where there's a slough, then you use this because this fluid keeps on diluting and breaking down the dead tissue. Then if there are a lot of seepage or secretions happening, then we use absorptive materials. So we can use foam, so that can be used. It also provides some cushioning. So sometimes patients are worried that, I need a good support around the wound so that there's no pain and all. So then generally we can use these dressings. Alginate is a seaweed which is very absorptive, and so these are very porous kind of material, and you can use them when again there's a lot of secretions and discharges there. Then you can use alginate. Cost becomes an issue. A lot of antimicrobial impregnated dressings are available. Silver dressings is very popular amongst burn patients, so you can use those. Iodine dressings are also available. Iodine based dressings are available. Same as the foams are also available, which can be applied. You can see if whatever the affordability of the patient is there, according to that you can use.